hyperinflation therapy. Inspiratory spirometer. Indication for inspiratory spirometer is atelectasis, fine crackles, surgery, and prevention of pneumonia. Indication for inspiratory spirometer is fine crackles, atelectasis, surgery, and prevention of pneumonia. Counterindication for inspiratory spirometer is head injury, pneumothorax, and cannot follow directions. Counterindications for inspiratory spirometer are head injury, pneumothorax, and cannot follow directions. How to calculate inspiratory spirometer goal: gender, age, and height. How to calculate inspiratory spirometer goal: gender, age, and height. Instruction and technique: breathe in with slow breath, tight seal, hold at the good mark. Instruction technique for inspiratory spirometer: breathe in slow, deep breath with a tight seal, hold at the good mark. When to discontinue inspiratory spirometer: when the patient is up and walking, when they hit 60% of their predicted goal, clear lung sounds, and they have a strong non-productive cough. When to discontinue the inspiratory spirometer: when the patient is up and walking, when the patient hits 60% of predicted, when the patient has clear lungs and a strong non-productive cough. Coughing and breathing exercises: direct cough instruction. Take a big deep breath, close glottis, bear down, and cough. Sit up right, and you want to cough preferably before you take medications, or a few hours after pain medications, because they can make you sick. Direct cough instructions are: take a big deep breath through your nose, inhale through the nose, close glottis, bear down, and exhale forcefully when you cough. Huff cough indication and instruction. Indication for huff cough is COPD. Instruction for huff coughing is open glottis. Keep the open glottis open. Take a big inhalation through your nose, close glottis, and then 3 times in a row. You want to keep that glottis open and keep huffing and coughing multiple times in a row when you're doing the huff cough, and it's best for COPD. Autogenic drainage instruction and indication. Autogenic drainage instruction is a phase cough. First phase is full inspiratory capacity. Inhale through your nose, close glottis, bear down. Then breathe out, followed by low volumes, which is the unsticking phase. And then 2 is low to middle volumes. And then exhale forcefully. That's the autogenic drainage instruction. Autogenic drainage instruction indication: phase cough, full inspiratory capacity followed by low volumes, low to middle volumes, then exhale forcefully. So the 3 steps. Diaphragmatic breathing instruction and indication: book on chest and take breath from diaphragm. Focus on using diaphragm to breathe. It's best for diaphragmatic breathing is best for bedridden patients or quadriplegic patients. Diaphragmatic breathing instructions: put a book on your chest or diaphragm. Take deep breaths, push the book up, focus on using the diaphragm to breathe. Diaphragmatic breathing is best for bedridden patients. Quad cough demo and indication: quadriplegic patients. Deep breath in, push up and in above belly button, and cough. Quad cough demo is a deep breath in, you push up and in above the belly button, and cough. Indication for quad cough are for quadriplegic patients. Cough assist machine, mechanical insufflation, exsufflation, MIE. Cough assist machine. Expiratory, longer ratio than inspiratory. It's usually a 1:2 or 2:3 ratio. Negative pressure, positive pressure. Negative pressure pulls out, positive pressure pushes in. It's for assist people with weak and infective coughs. Interpercussive therapies are used to mobilize secretions and recruit alveoli. Interpercussive therapy, PEP therapy. PEP therapy is use the pickle, positive expiratory pressure. Flutter valve uses PEP in oscillation. PEP opens up, recruits the alveoli, and oscillation vibrates and mobilizes the secretions. That's what the flutter valve works by. Acapella works by PEP in oscillation. Flutter, I think acapella is also the pickle device. Percussive nebulizer works by PEP in oscillation. You can use a nebulizer. Percussive nebulizer works by PEP in oscillation. I think that's a Robica. Percussive nebulizer is the Robica. Works by PEP in oscillation and can use nebulizer. Metadeb is a high-frequency positive expiratory pressure, as well as high-frequency oscillation pressure. You can also aerosolize, and you can adjust the flow. How to use a Metadeb: tight seal and blow through. Metadebs usually take around 10 to 12 minutes per treatment. Chest physical therapy and for atelectasis. Here are the positions. Upper lobes apical segment, that's sitting upright on the front up by the shoulders. Upper lobes anterior segment, you're laying flat on your back, pounding the upper lobes on the anterior side. Upper lobes posterior segment, you're sitting upright, lean forward, tapping them on the back. Left upper lobe lingular segment, you're at a 14 inches, laying down towards the ground on your right side, turning that left upper lobe. Right middle lobe lateral medial segment at 14 inches. That's just flat on your back at a 14-inch angle. Lower lobes superior segment, that's flat on your belly. Lower lobes lateral basal segment at 18 inches. Lay on your right side and tap towards the right or the lateral basal on your back. Lower lobes anterior basal segment, you lay on your left side, tap in the side, lower lobes, not lateral towards the back, but on the side. Lower lobes posterior basal segment, flat on your belly at an 18-inch angle. See if I can pop up what I was was looking at before. Okay. Mobilize secretions, cuff, chest physical therapy for atelectasis, chest physical therapy for atelectasis. So we went over the positions, drug drainage positions, how to perform procedure, cuff, hands, and percuss. 3 to 5 minutes in each position, in the drainage, postural drainage positions. Interpercussive therapies. Chest physical therapy for atelectasis. Takes 3 to 5 minutes. Tap each position for 3 to 5 minutes when they're and use postural drainage. Adult cup, pediatric cup, and baby cup. Monitoring patient response, vitals and lungs. Complication, pulmonary embolism when percussive therapies. Embu bags types: self-inflated embu bag as well as flow-inflated embu bag. Self-inflated embu bag does not work with CPAP. Use one hand to bag and gives about 500 milliliters per breath. You should give a breath every about 4 to 5 seconds, or 5 seconds. Flow inflated embu bags work best with CPAP, or can use CPAP. Works best with infants and kids. They have a continuous flow. You can bag one-handed. Gives 500 milliliters per breath with embu bags. You want to lift the jaw up and hold with a tight C cuff. Hold mask with tight C cuff. Embu bag components, valves are 22 millimeters, and they're one-way valves. Reservoir holds oxygen at the end of max, so every breath is 100% oxygen. Volume delivered from an embu bag is 500 milliliters with one hand. Technique: hold jaw up. C grip for good seal. Airways indication: narrow nasopharyngeal airway, indication to initiate suctioning and vent. Oropharyngeal airway to lift tongue on unconscious patients. Intubated pre-check. Check cuff. Check laryngeal scope working. Lights. Bag with embu bag. Bag mask to 100% oxygen. Lube endotracheal tube, and check suctioning tube. Intubation placement check. X-ray, listen over stomach, bilateral breath sounds, condensation on endotracheal tube, and CO2 detector. Intubation technique: Mack or Miller blade. Supplies to assist endotracheal tubes. For intubation, you want 3 endotracheal tubes, a laryngoscope, Mack or Miller blade, the correct size, syringe, lube, CO2 detector, laryngoscope, tube exchanger, tube securement, suctioning, embu bag and mask, tube securement. I don't know if I hit everything on that one. Embu bag and mask. We'll have to go back to that. Different types of airways and their indication. Different types of airways are LMAs, OPA, NPA, ETTs, tracheostomy tubes, LMAs, and LMAs. Trach indication. If you're going to put a trach in, They got to be on an endotracheal tube for at least 14 days. Uh, tracheostomies are for long-term ventilation, or if the patient has facial trauma and still needs ventilation. Collins tube used for independent lung ventilation. Collins tubes have two cuffs. They have a bronchial and a tracheal cuff. So you can ventilate the trachea and the bronchial for independent lung ventilation. Combi tube / king tube, they're the same thing. Combi tube is the longer one, king tube is the shorter one. They are used for blind insertion. Bottom part inserts into the esophagus. And the top part has a cuff for the oral pharynx, and the bottom part has a cuff for the esophagus, and it ventilates in the combi tube and the king's tube ventilate through the larynx into the vocal cords. King's tube replaced the combi tube. Laryngeal mask airway sits on top of epiglottis into vocal cords. Low flow used in surgery. Two types. There are two types: gel and PVC. Polyvinyl chloride. Polyvinyl chloride. Endotracheal tubes are made of polyvinyl chloride, as well as laryngeal mass airway and nasopharyngeal airway made of polyvinyl chloride. Laryngeal mass airway are used in surgery. It sits on top of the epiglottis and ventilates in the vocal cords. Have gel and polyvinyl chloride laryngeal mass airways. Foam and they laryngeal mass airways are sized based off of weight. Foam cuff endotracheal tube. Foam creates a tight seal. CAS, high-low evac endotracheal tube, stands for continuous aspiration subglottis secretion. Subglottis secretion. CAS endotracheal tube is used to suction and prevent ventilator-associated pneumonia. Suctioning is above the cuff. Oral pharyngeal airway measures from chin to earlobe. Insert sideways, rotate, lift tongue on unconscious patients. Nasal pharyngeal airway used for suctioning, measure tip to nose to earlobe. Insert with lube, twist medially. When the nasal pharyngeal airway is in right, it sits right behind the uvula, and is used in semi-conscious patients. Trach are used for long-term ventilation. Has an inner cannula, obturator, an outer cannula, as well as a flange. Jackson trach, silver stainless steel. Jackson trachs are cuffless and used for long-term ventilation. Tracheostomy tubes, Jackson, Carl's double lumen endotracheal tube. That's for independent lung ventilation. Esophageal tracheal combi tube is used places in the esophagus and oropharyngeal and ventilates through the vocal cords in the laryngeal area. Laryngeal mass airway is used in surgery. High-low evac tube. CAS is used for suctioning. Suctioning is above the cuff. Syringe, cuff. Okay, combi tube, king tube. Yeah, gone over the combi tube twice. Tube material and markings. So when you place the tube in, you want it at 21 to 26 centimeters, or 2 to 4 centimeters above carina, 21 to 26 centimeters at the teeth. Intubation, take our dentures. Endotracheal tubes are measured by height. Laryngeal mass airways are measured by weight. Indication to take intubation, take our dentures. Indication for intubation, protect airways, initiate mechanical ventilation, impending respiratory failure. You want to keep those airways open, use for suctioning, mechanical ventilation, protect airways. Those are reasons we would use intubation. Reasons we would use tracheostomies in the throat. In the second tracheal ring is where it places. For facial damage, long-term ventilation, and upper airway swelling. I want to start that for the tracheostomy. Back to intubations. Tubes and supplies. We want to use the McGill to remove suctioning. We want the McGill to remove obstructions, suctioning to remove secretions, stylet to put the endotracheal tube in. We want 3 endotracheal tubes of different sizes, one large, one small, one regular. 8 to 8.5 for males and 7 to 7.5 for females. For endotracheal tubes, bite blocks. We want bite blocks for tube supplies. We want lube to get the tube in. We want tape securement device. We want an ambu bag with mask, ventilate to 100% for 2 to 5 minutes. We want a syringe to inflate the cuffs. We want to check the cuffs, make sure they work. We want towels, a laryngoscope. Technique for intubation is sniffing position, see vocal cords, laryngoscope, up and away, stylet tube. 21 to 25 centimeters at the teeth and 2 to 4 centimeters. So when we intubate, you want it 21 to 25 centimeters at the teeth, endotracheal tube. You want 2 to 4 centimeters above the carina. Hold endotracheal tube, pull stylet, check if ventilation secure, check equipment, oxygenate to 100% intubation. Again, endotracheal tube sizes, for males it's 8 to 8.5, females it's 7 to 7.5. Hope y'all enjoy. Peace out. See you on the next video. Bye.